Let's continue. I would like to introduce our first guest, Ruth Zimmermann. She will talk about the surveillance of viral hepatitis in Germany. She will present the Robert Koch Institute's publication on the increase of reported hepatitis B and C cases in her country. She is an epidemiologist at the Epidemiology Department of Infectious Disease at the Robert Koch Institute. She is a medical doctor by formation and has completed a Master's of Public Health. Her interests are in the surveillance of hepatitis B, C, and D, and HIV in the general population, but also specifically in groups at risk. She is she's leading a project of a multi-center zero-behavioral survey among people who inject drugs. Please, Ruth Zimmermann.
Thank you very much for the kind introduction, and also thanks very much for inviting me to this symposium. The program looks very interesting, and I would really like to be with you in Bern. But actually, I'm currently joining the European Harm Reduction Conference in Warsaw, so I cannot be with you. But nevertheless, I will try to give you an overview about the epidemiological situation of hepatitis B and C in Germany, and with a focus on some recent developments. So to start, some context information. So we are a federal republic with 83 million inhabitants. And our public health system is organized at 3 levels, with the national level being responsible for emission of guidelines and defining cases for notifiable diseases, giving advice and support to the federal states, and assuring data quality. Then we have the 16 federal states, and they are issuing this contact tracing, outbreak investigations.
Do you hear me?
Yeah.
Could you maybe back like 5 sentences, because we didn't hear you for a moment.
Oh, I'm sorry for that.
No problem.
Yes, I presented the federal states with their tasks, and the local level, the districts with the local public health authorities and their tasks. So they, at the local level, this is the level where the response takes place. Is that okay now? Is it working?
It works, thanks.
Okay. So if not, please just interrupt me. So Germany is a low prevalence country for viral hepatitis B and C, with a low prevalence in the general population. As you can see on the table on the left side, prevalence is estimated to be below 0.3% for both infections, but we have concentrated epidemics in key populations, as you can see in the table again. For some of the key populations, we don't have good data. So for example, for people in prison, we don't have any recent estimates. We are doing a study next year in one prison, so hopefully we'll get some better data then. Regarding the size of the infected population, we have a good, robust estimate for hepatitis C, recently done in an ECDC project. This is the green field. And we have also a baseline estimate for hepatitis B for 2013 that is currently being updated in an ECDC project. And you can also see that the estimated share of key populations of the infected population is quite huge. So we estimate that more than 50% of Hep B infections are among people with a history of migration, and 50% of HCV infections are among people who inject drugs or who have injected drugs. So how is the surveillance system organized? It is based on the Infection Protection Act, and this regulates which diseases are notifiable, who is required to report, how reporting should how reporting should be carried out, and which information should be passed on. Regarding hepatitis B and C, so these diseases are notified from the local level by doctors, physicians, and each positive test results by the labs. And this is being notified to the local health authority by name. From there, then the local health authority will try to collect additional information to the case, for example, clinical symptoms, hospitalization, way of transmission, vaccination status, nationality of the case, suspected country of origin, stage of the disease, and then transmits the notification without the name, takes off the name and transmits the notification to the federal state level and from there to the national level. So how are the trends of case numbers of hepatitis B and C? I start with hepatitis B. You can see here that in historical years, so since 2001, when this legal act was funded, until the year 2014, we had only a surveillance for acute hepatitis B. And cases had to include clinical symptoms, and the case numbers were quite low. In 2015, the case definition was changed, and we decided that clinical symptoms were no longer required to fulfill the case definition. So therefore, also cases with unknown stage of disease started to be reported and also transmitted to the national level. And in 2017, again, another change happened. It was defined that any evidence of HBV should be reported, regardless, again, of clinical symptoms and stage of the disease. And the case numbers increased, as you can see here. And finally, in 2019, it was again decided that also chronic cases should be published at the national level. So you can see the chronic or the cases with chronic stage of disease in yellow. And so with that, really case numbers grew importantly. And you can see the major increase in 2022 and 2023. So these are the 2 years we will look closer at a bit later. Regarding hepatitis C, since it's difficult to distinguish the stage of the disease by lab markers in hepatitis C, chronic cases and also cases without clinical symptoms were always among the notified cases. And we had much more hepatitis B cases than Hep B historically, also because until 2015, the case definition included also cases just with confirmed antibodies. That was changed in 2015, and since then, only cases with direct evidence, so viremic cases, were fulfilling the case definition, and the number of cases first decreased. They also increased because of the DAAs coming to the German market, and so this was a motivation to screen more patients, find more patients, and treat them. So this had also impacted on case numbers. But with this narrowing of the case definition, first we saw this decrease in 2015 in cases. And you can see here also that in 2020 and 2021, the same as for hepatitis B, we saw this dip or this decrease in case numbers, and that was probably due to the pandemic, and it was also seen many other countries. And then again, also for Hep C, this huge increase in case numbers in 2022 and 2023. So when we just look at the last years, in 2023, we had more than 22,000 HBV and more than 10,000 HCV cases that were transmitted to the Robert Koch Institute, and that was an important increase in case numbers since already since 2022, but the major increase started already in 2022, as you can see. So what events could have impacted on these changes in case numbers. I already mentioned the changes in the surveillance system, each time impacting on case numbers. During the COVID-19 pandemic, I also hinted at that. We saw decreasing case numbers. Then in February 2022, the Russian war in Ukraine started, another important event, as you all know. In end of 2021, a new screening was implemented in Germany. This is integrated in a general health checkup, and that was introduced in end of 2021. And finally, since the beginning of 2022, the reporting of cases from the labs to the local public health authority changed to a completely electronic, automated system. So we wanted to understand the reasons for the major rise and also try to attribute them in case numbers since 2022. And we had three hypotheses. The first dimension change to the electronic transmission of lab notifications had impacted on case numbers. Second, refugee migration from Ukraine. And the third, the introduction of this new screening has led to an increase in case numbers. So we try to investigate the impact of these events on the increase of case numbers by using our surveillance data. So what did we do? We descriptively analyzed the surveillance data for HPV and HCV for the years 2019 to 23. And we described changes in proportions of selected characteristics over time. And we compared the last year versus the mean of the 2019 to 2021, so the years before this increase started. And we also showed changes in weekly and monthly incidences over time by selected characteristics and use trend description using locally estimated scatterplot smoothing. And then to understand the impact of the new electronic reporting, we try to identify potential duplicates by matching electronic lab notifications with associated HPV-HCV surveillance data. So, and for that, we used information regarding birth date, gender, and district. So I start with the latter. This slide shows how our new electronic reporting system called the DEMIS, Deutsches Elektronisches Meldesystem, is organized. It's just, I mean, it's a complicated thing. I think very important for this presentation is just to know that the notification from the lab to the local public health authority is no longer something actively done by the lab, but it's really automatically. And so each time they have a positive test result, it's sent to the local health department. And in the future, also physicians and other notifiable organizations will be linked to this DEMIS. So our dream of a completely electronic system maybe becomes true in the future. So when we compare the number of lab notifications with the number of cases in the surveillance system over time, you can see that the proportion of cases with more than one notification increased in 2022 as compared to previous years. So this means that one case had several notifications coming from the lab. And we also found potential duplicates in 6% of HPV and 3% of HCV cases. So this means that notifications that belong to one case were maybe not merged together and yes, put together for one case. We also had some discussions with different local public health authorities about that. And we found that a proportion of cases seems to be retransmitted when newly tested and newly notified. And this might be due to software changes in the system without transfer of personal data. So they can't put together cases that belong together. and short deletion periods of personal data at the local level also. So data protection seems to be an issue. Coming to the next analysis. So what about the impact of refugee migration? So as you all know, since 24th February 2022, in Germany, more than 1.2 million refugees from Ukraine were registered. And as we all know, the prevalence of viral hepatitis is much higher than in Germany. It's estimated that there is a prevalence of 2.7% of HCV and 1.4% of HPV. And refugees from Ukraine had very early access to the German healthcare system. So this means people with already diagnosed HPV or HCV infection could be treated very early and can still be treated. And people can also, of course, go to testing and screening, including medical checkups, if they have not been diagnosed before. So to analyze that, we had a look at cases by country of origin over time. Country of origin is computed by either nationality or country of birth, and this is only reported in about 50% of cases. So we are often missing this information. But this figure shows HCV cases, and you can see the increase of cases with unknown country of origin, which is the purple line of German cases, also of cases with missing information, but also of cases from Ukraine, shown by the violet line for hepatitis C. Regarding hepatitis B, this increase was not that large. The rise was rather seen in cases with unknown country of origin and others. So finally, what is the impact of the screening? To understand this, we analyzed cases over time by age groups. So this figure shows the increase of incidence in all age groups for hepatitis B and C since the beginning of 2022, but in particular, this increase is major in the age group 35 to 59 years, which is the green line, and not so important in younger age groups. And this increase was even much more pronounced in 2022. So when the new screening was introduced for the first year, you can see here that older age groups, particular for hepatitis B, really had a strong increase. So also in the 60 to 79 years, which is the yellow line. We then compared the observed proportions of cases aged 35 years and older, and of cases with Ukraine as country of origin in the year 2023 with the expected proportions. And for the expected proportions, we decided to go for the mean of proportions from 2019 to 2021. So for HBV, we would have expected 66% of cases being older than 35 years, but we have observed 80% of cases. So a difference of 14% points. And so this is probably an increase which is attributed to the new screening, together with this change in publishing also, or making chronic cases also notifiable. Regarding cases from Ukraine, we would have expected only a few cases, 0.2%, based on previous numbers, but observed 2.6%. And for hepatitis C, in 2023, we observed even less cases aged 35 years and older than expected, but saw much more cases from Ukraine than expected. So representing an also major increase. So in summary, I think I showed that surveillance data is very much influenced by numerous effects. So each time we change the surveillance system, this impacts on case numbers. And of course, it's also impacted by new screenings or treatment strategies, and of course, also external factors like a war in Ukraine or a pandemic might influence. So we saw really this major increase of notifications in age groups 35 years, especially for hepatitis B. The effect for hepatitis C was much smaller and more pronounced in the first year of the screening. And the increase of HCV notifications seems to be mainly due to cases from Ukraine, at least in 2023. And there the effect is smaller on HBV. However, a quantitative attribution of the reasons is not possible just with surveillance data. So we would need other data sources for that. So, and I want to show you two more slides. What else do we know about this new screening? So this is recent publications that just came out. So this figure shows data from one of the bigger laboratories in Germany. On the left side of the figure, you can see this huge increase in the number of laboratory tests performed for hepatitis B and C since this screening is being implemented. And on the right side, you can see also a major increase in the number of positive test results for HCV, more pronounced than for HBV because it's antibody. And a very recent publication from last week reports on the number of screening tests from billing data since the Q4 of 2021 until Q3 of 2023, so the first 1.5 years since the screening is being implemented, and shows also the numbers of positive screening tests that were then reflex tested with PCR. So I can't see the proportions because there's something on the screen, but in this publication, then they then used the proportions coming from the publication on the left side of viremic cases among the positively screened cases and calculated with that the probable number of viremic HBV and HCV cases, as you can see. And it's really a huge number that seems to be found by this new screening. So this underlines that probably really for hepatitis B, we see this increase in case numbers due to the implementation of the new screening and the changes in the surveillance system. For hepatitis C, it's a bit less. But we also see an re-increase of the numbers treated for hepatitis C. So we calculate this on a regular basis from pharmacy sales data among patients with social health insurance. And we just calculate the numbers of DAA packages times the treatment duration per regimen to have the number of patients treated. And you can see that since 2022, numbers seem to re-increase in Germany. So, and with that, I want to thank all who contributed to this analysis, in particular my colleagues of the hepatitis team at RKI, above all Renke Bialas, who did this analysis for 2022 and wrote the publication also. Thank you for your attention, and I'm happy to take questions.
Thank you very much. That was absolutely fascinating. And a good lesson for Switzerland. It shows how important a wide and thorough screening is. What about questions now from the online people? Do you have anything for me? Not at the moment. Is there anybody in here that would like to ask Ruth Zimmermann some questions? Yes?
Thank you. Hi. So my name is Beatrice Vetter, and I work for FIND, an NGO looking after hepatitis in low and middle income countries. But that aside, my question is if you have any statistical data on blood transfusions, because I understand they're obviously also being screened for hepatitis, and have you also seen any changes there?
So in Germany we have another act that is laying the ground for screening of donors. This data is being analyzed at my department, but I cannot say what the trend is if we find more infections among blood donors than previously. Blood transfusions, I know that the last transmission of HCV by a blood transfusion took place in 2014, and since then no further infection was transmitted via blood transfusion. So if you mean this, this is really very, very low. They are doing pooled testing of each blood product. So I think the risk to be infected by blood transfusion in Germany is really very, very low.
Any other questions? Yes, please. Just a moment.
Hello, I'm Pascal de la Santa. I'm a GP in Switzerland. I wanted to ask about the cost effectiveness of general screening with HBV and HCV. Did you see already some results? Or the decision was based on other countries that took that decision?
As far as I know, there was no cost effectiveness analysis being done. And honestly, when it was planned, several people were asked to guide the process, and we always said, okay, screening in the general population is nice, but there has to be screening in key populations. We know that many infections are there, and we all did not expect such a success of this general population screening. We think it is due really to the fact, for example, that for hepatitis B, many people with a history of migration are also well integrated now in the country. I mean, this is former migration from Turkey, so high prevalence countries for hepatitis B, and we know it from first surveys in hepatological centers that that a lot of cases occur among or are being found now among people with a history of migration, for example, from Turkey, Romania, and so on. So this is really a success that we wouldn't have expected. And as far as I know, there were no cost effectiveness studies being done previously.
It's Philip Bruckmann. Hello, Ruth. Thank you very much for this very interesting presentation. One question, you removed clinical symptoms from the case definition. Now, in retrospective, what would you say were the advantages and disadvantages of this change?
I mean, it's with removing the clinical symptoms to be required in the notification. Of course, this widens the case definition, and therefore you see many more cases also with probably not viremic infection and so on. But it makes your surveillance system more sensitive, right? Because you capture more cases. But then, of course, it's much more work for the local level to investigate the case and also to do this in a I want to say that the local public health departments, I mean, they do a great job, but they work at very heterogeneously. So we know that in some local public health departments, they really call the case, call the doctor, and then will also try to say, yes, you should go and see a hepatologist and maybe get treatment and so on. And others, they don't do anything. So it's very dependent on where you live and which public health department is responsible for you. But I think to remove the clinical requirements, it was a good step because the surveillance system gets much more sensitive.
Hello, my name is Erica Castro. Thank you for the presentation. I was interested to know more about the migrant population you were able to diagnose with chronic hepatitis C. How did you achieve to keep them into care and very quickly put them on treatment, as you said? Because it's not the same system, the screening system and the system that treats patients. So I was interested to know more about.
Yeah, I think some other countries did that as well. I mean, it was just implemented in Germany for refugee migrants coming from Ukraine. So they were, other than refugees coming from other countries, directly integrated, or they had access to the German health insurance, and therefore also to all, to the complete medical system in place for insured people. And that was an exception that was done for Ukrainian refugees in contrast to refugees from other countries. Does this answer your question? And I think therefore also because they had access, they could also go and see a GP or an infectious disease specialist doctor and get treatment for their viral hepatitis or were tested for viral hepatitis.
Any more questions? I think that's it. I would like to thank you very, very much. It was super interesting, and it's great that you took the time wherever you are at the moment. And a welcome and a thank from everybody, and goodbye.
Thank you very much and have a good afternoon. I'm sorry I cannot participate.